Good afternoon, everyone. I'd like to thank you, the chairs and the sages, for giving me the chance to speak here. Okay, I'm a bit nervous. It's okay. There's significant concern about surgical smoke after COVID-19 pandemic, especially aerosol transmission. Since then, I also got a lot of questions from my colleagues about surgical smoke. My presentation is about today an overview of surgical smoke, and also I will show my recent research works. First of all, what is a surgical smoke? Surgical energy devices generated fine particles and ultrafine particles containing the water and chemicals and the VOCs, volatile organic compounds, and the dead and the live tissue materials, and the bacteria, and the viruses, and the malignant cells. We all know surgical smoke is not good for patients and the surgical teams. As you can see here, there are more than 150 chemicals and toxic substances have been identified in surgical smoke. We know surgical smell is not good and not healthy at all. The particles generated are very, very small and can reach deep region of the lung. And from the literature, monopolar generates the smallest particle, smaller than 0.1 micron. Laser created a bit larger, and the ultrasonic scalpel generates the largest particle, 0.35 to 6.5 microns. However, the ultrasonic study used a particle counter that only measured that range. There's no information about particle sizes distribution smaller than 0.35 microns and larger than 6.5 microns. In addition, only ultrasonic bone scalpels were analyzed, which we don't use in practice as a MIS surgeon, right? In general, these particles flow greater distance up to 1 meter, I think more than that, and the closer you are, the more surgical smoke you would inhale. The risk of smoke exposure depends on the OR airflow system and the surgical techniques and the types of the energy devices and the procedures and how to use the devices and the use of the surgical smoke evacuator, etc. Limited data are available on surgical smoke generated by advanced energy devices such as ultrasonic sealers and vessel sealers that we are using every day in the clinical setting. We found advanced energy devices consistently that generate the particle ranging from 0.1 to 10 micron with greater concentration in the 0.1 to 0.3 micron zones, which there's no significant difference among the energy devices. The monopolar, vessel sealer, and ultrasonic seals all same. As you can see here, that any of these energy devices generated surgical smoke. Those devices just destroy the tissue, and the smoke is almost same. Here is our preliminary data. And as you can see here in the monopolar devices, the higher power setting, the more VOCs you generate. This might be related to interaction between the arc discharge and the plasma and radical reactions, which is a little bit difficult to understand. How about the advanced energy devices? Ultrasonic scissors and vessel sealers generated almost no VOCs. We can say advanced surgical energy is less toxic than electrosurgery, monopolar electrosurgery. Here, major symptoms when exposing surgical smoke, respiratory and cardiovascular symptoms such as cough and bronchitis and asthma and COPD, etc. Inflammation of the eyes and watering the eyes, headache, nausea and dizziness. And there are no mutagenic and carcinogenic effects. And there are also cumulative risks. Oral staff also experience the fatigue and skin irritation and allergies. The study reported the level of the toxic substances were increased after lap cholecystectomy. How about the infectious risk? Several bacteria and viruses have been identified in the surgical smoke. Oropharyngeal lesions developed after exposure to HPV ablation procedures. The review literature mentioned that the surgical smoke is more likely to contain the viable agent when large and low temperature particles are generated. Okay, sometimes those risks I mentioned are underestimated because of the limited smoke visualization in the clinical setting. Surgeons don't believe in something what surgeon cannot see. So let me visualize surgical smoke here. You will be surprised. So the fine particles and the ultrafine particles flow for a while more than we expect because of the side of the room are not effectively ventilated in the room. So this is an illumination of the most air ventilation system today. This is a limitation of the most air ventilation system today. So air ventilation system provides a clean environment around the patient, basically to prevent the surgical site infections. It is not intended to reduce the surgical smoke exposure. We can protect the patient, which is good, but we are not able to prevent our team members from inhaling surgical smoke. Here, the impact of ceiling lights on the airflow, and the surgical smoke. You can see the difference between the position of the OR lights. OR ceiling lights block clean airflow from ceiling and then increase the smoke exposure risk. The surgical team needs to be aware of this. As you can see here, we can decrease the exposure risk significantly by using surgical smoke evacuator. Can you see that? You can see how effective a smoke evacuator is. During MIS procedure, we might lose visibility in the surgical field due to the surgical smoke. This causes the delay of the procedures and unintended injuries. In minimally invasive surgery, the risk might not be significant when comparing open surgery. However, when inserting or removing the instrument, smoke leaks out of ports. Therefore, we should apply best practice, Dr. Mikami already told you, to minimize the leakage. Incision for ports should be as small as possible and keep low CO2 pressure and use a smoke evacuator or a proper filtration. In summary, surgical smoke contains a toxic gas and vapors, and surgical smoke can be generated by any energy devices. Perhaps advanced energy devices is less harmful. Surgical smoke is a hazard to patient and/or personnel. Thank you.